Neurogenesis is a new concept in Alzheimer's research. As you know, the past 20 plus years, there is a dominant hypothesis. The amyloid cascade hypothesis has been around for a number of years. However, the result of the hypothesis so very unfruitful, and there's a lot of challenge. So we believe that the neurogenesis hypothesis can serve as an alternate approach. And at the conference, AAIC conference 2020 in San Diego, we presenting the hypothesis with the research clinical data of our drug, showing that the hypothesis could be valid, and we encourage all the researchers to look closely to it, and this offer an alternate approach for the current hypothesis. What about the human hippocampal neurogenesis? One of the unexplained observations of Alzheimer's disease that the neurodegenerative takes place in the lateral entorhinal cortex before all the brain areas. And by the way, this brain area does not have elevated levels of amyloid peptides in comparison with the undamaged regions. So the question is, what is the cause of the vulnerability of the entorhinal cortex? As you know, one unique feature of the lateral entorhinal cortex is that it has newborn neurons that have undergone adult neurogenesis in the dentate gyrus of the hippocampus. We talk about adult neurogenesis. As you know, we all born and our brain generate new neurons when we were very small in the baby. But the question is whether when you become the adult, is the neurogenesis still there or not? And the answer is that the adult neurogenesis still exists when you even get into up to 90 years of age. Okay, and you know the hippocampus is the brain area which is very critical for learning and memory. It contains neuroprotective cells that continue to generate new neurons throughout life. And this process we call hippocampal neurogenesis. Okay, so let me take a few moments to outline the hypothesis. The hippocampal neurogenesis is persistent throughout even to the 10th decade of human life. It is detectable in patients with Alzheimer's disease. In subjects at 90 years of age, nestin, SOX2, and neurogenesis cells and DCX plus neuroblast and immature neurons were detected, according to Professor Jimenez and Tobin last couple of years publication given here. And it was observed that there is a marked and progressive decline of DCX and cell numbers in Alzheimer's disease patients as compared with healthy individuals. The neurogenesis framework includes neuroanatomically distribution of damaged neurons, the relationship between Alzheimer's disease, glial cells, and APOE is well established. The adult hippocampal neurogenesis impairment compromise the hippocampal function in Alzheimer's disease as well as mild cognitive impairment. This indicates that the reduced adult hippocampal neurogenesis cause memory impairments and cognitive deterioration in the disease. The adult hippocampal neurogenesis impairment appear to take place prior to the presence of senile plaques and neurofibrillary tangles, both of which are known as hallmark of the Alzheimer's disease in the dentate gyrus. So the point I want to make is that before we're able to observe and detect or measure amyloid beta, a certain phenomenon takes place prior to that. We believe that the adult hippocampal neurogenesis takes place prior to that. So over the past years, people talk about we need to start the treatment well before we can measure the amyloid beta. How? The question is it such an ideal situation if one can learn and identify where is the problem initiated. So we believe in our hypothesis that the adult hippocampal neurogenesis takes place prior to the presence or the ability to detect amyloid beta. So in our research strategies, we believe that inducing the adult hippocampal neurogenesis together with the brain-derived neurotrophic factor, BDNF, can improve cognition functions in the Alzheimer's disease. And we have animal studies demonstrate that. So we believe that stimulating the inherent adult hippocampal neurogenesis could serve as the therapeutic target for improving cognitive functions and promoting synaptic resilience. So, where the proof over the past years, we have researched on the new compound. We call it NA-831. It is a small drug molecule. It easily crosses the blood-brain barrier with remarkable bioavailability. It exhibits both neuroprotection and neurogenesis based on our animal studies. It is an oral formulation, very easily to be administered to the patient orally. The patient can take between 10 milligrams to 30 milligrams per day based on our clinical phase 1 and phase 2 data. Phase 1 show it has no adverse effect. The drug is well tolerated up to 50 milligrams per day. We had shown the predictable pharmacokinetics, including dose-dependent exposure, linearity, and low variability. We present the clinical data of phase 2A for the drug at the previous conference, and this year we're able to articulate and present more data to support the hypothesis of neurogenesis. At the same time, we can understand and explain the mechanism of action of the drug. So, the mechanism of the drug, NA-31, can explain that it is a positive modulator of AMPA receptors. As you know, AMPA receptors are the major player for controlling synaptic plasticity and memory functions in the hippocampus. The main neuropsychotropic effect of NA-31 are the result of accumulation of BDNF upon the activation of AMPA receptors. And BDNF support the neuron survival, maturation, and maintenance in healthy brains. And BDNF is shown to be very crucial in the learning and memory process. So that's why we like to focus on BDNF, and I think this can give us a certain clue how to control and how to manage and how to mitigate the amyloid beta, and can be a mechanism action for treatment of Alzheimer's disease. And animal studies show that the BDNF level in hippocampus reduced and significant by the administration of NA-831, and it showed significant improvement in animals by stimulating the neurogenesis. Our drug in the phase 2A and also previous animal data demonstrate the hypothesis that the drug serves as a catalyst to restore neurogenesis in Alzheimer's patients by increasing the DCX, PCNA cells with higher numbers of neuroblast, leading to our observation that improve the cognitive functions. And the data of the phase 2A, we did a phase 2A clinical trial. It is a randomized placebo double-blind control with total 56 patients in a small number of patients, about 32 patients with MCI and 24 patients with mild and moderate Alzheimer's. The patient with MCI received about 10 milligrams of the drug or the placebo orally per day, and patients with mild and moderate AD receive 30 milligrams of the drug or the placebo orally per day. And we have a long list of key inclusion, but basically the subject with MCI to meet the National Institute of Aging, NIA, and Alzheimer's Disease Association, AA, core clinical criteria for mild cognitive impairment due to Alzheimer's disease. And subject will have a CDR score of 0.5 and memory box score of 0.5 or greater at the screening and baseline with the MMSE score equal or greater than 22. These are for the MCI patient, but for the patient with mild and moderate Alzheimer's disease, they have to meet the NIA and AA core of clinical criteria with the MMSE between the range of 17 and 21. The primary outcome measures all the changes in the Alzheimer's disease assessment scale cognitive subscale. We use the ADAS-Cog 13 elements, and also the brief cognitive rating scale, and also clinician interview-based impression of change plus caregiver input, BIC plus, after 6 months. And we have a long list of data presented at conference, but for the sake of interview, I'd like to give you a big summary, and then I'd like to show you a dashboard data. Based on the brief cognitive rating scale during the treatment, patients show significant improvement over 24 weeks in the area of ability to concentrate, short-term memory, long-term memory, ability to self-care, orientation, and cognitive functions. These are the quality of care. We have data to show that, but it's too lengthy to show. But let me focus on the ADAS-Cog 13 to show a significant improvement for your consideration. ADAS-Cog 13 scale data for the patients with the MCI over 24 weeks. As you see in the graph, the blue line represents the patient cohort take the placebo, and the red line represents the patient cohort take the drug over 24 weeks. And the difference of the ADAS-Cog scale compared with the baseline is significant, about 3.4 with a difference here. This will compare to patients with Alzheimer's disease. And you see there are more profound change over 24 weeks in ADAS-Cog 13 scale. The red line represents the drug treatment cohort, and the blue line represents the patient take the placebo. And the difference here is that we found the NA-831 shows significant improvement of MCI patients with ADAS-Cog 13 score of average of 3.4 as compared with the placebo after 24 weeks of treatment with the P equals 0.1 ITT. And this is for the cohort with MCI. For the patient with the mild and moderate Alzheimer's disease, the ADAS-Cog 13 score change of an average of 4.1 as compared to the placebo after 24 weeks of treatment. And this is significant. Let me give you a sense of what it means. The FDA guideline is that the ADAS-Cog 13 change has to be above 2.7 to be considered significant. Less than that, it's very insignificant or very borderline. So by crossing over 3.4, we believe the drug, even though in a small number of patients for MCI and AD patients, it gives us a sense it is promising to go further. We plan to do a phase 2B and also phase 3 by end of the year 2022. So in the conclusion, NA-831 were well tolerated at 30 milligrams per day in the study for people with a mild and moderate Alzheimer's disease group report minor headaches and diarrhea. There were no serious adverse effects observed. And in conclusion, we believe that the drug demonstrates a proof of safety and efficacy as a potential disease-modified drug for improving cognitive functions and overall quality of life for patients with MCI and patients with mild and moderate Alzheimer's disease. So now, drug based on the neurogenesis hypothesis, we suggest that the neurogenesis hypothesis for Alzheimer's disease is a viable guidance for further research, and it is a guidance work in conjunction potential replacement of the amyloid cascade hypothesis. So in conclusion, I want to use a quote of Professor Nicola Tony. He said that even if drug companies could develop therapeutics that block or reduce the amyloid beta, they will not able to reverse the damage. But the adult neurogenesis in the hippocampus could be a way to partially right that wrong. So we believe this statement has some valid and our data show it's promising for further research. With that, thank you very much for your attention.